So again, thank you all for being here. Putting this together about understanding the less common dementias is very interesting to learn about all of the dementias that are out there and what makes them unique, but also knowing that, you know, they're still considered a dementia. We still don't know a whole lot about progressive dementias, even the more common ones like your Alzheimer's disease and Lewy body dementia. We're still doing a lot of research. There's still a lot of clinical trials. There's still a lot of theories out there about why do we get them? How do we help cure them? How can we prevent them? So a lot of information, a lot of research still needs to go into this, and particularly these less common dementias, because they don't get as much money, right? Not as many people get them. But keep that in mind as we're talking through these 4 different ones that we're really going to dive deep in today. So we'll talk about traumatic brain injury and chronic traumatic encephalopathy, Huntington's disease, Creutzfeldt-Jakob disease, and normal pressure hydrocephalus. You might have heard of some of these, you might not have, but we'll talk about the differences between those, symptoms of them, and some diagnosis and treatment for each one of those. But again, remembering there are about 130 different types of progressive dementia under that umbrella term. You know, we've been talking about the more common ones, the Alzheimer's disease, the vascular, the Lewy body, the frontotemporal, Parkinson's dementia. But knowing, you know, there's a lot of things underneath that umbrella. Some of them are genetic. We'll kind of cover those today. Some can be from an infection. Some we just don't know why we may get them or not get them. And knowing that dementia is a term used to describe a wide range of conditions, severity of what causes changes to the brain and how that affects a person. So starting off with the traumatic brain injury, because most of us have heard TBI as a traumatic brain injury, and this does have a wide range of severity and symptoms that can come along with it. And the symptoms can be physical, cognitive, and emotional. With traumatic brain injuries, symptoms can occur immediately after the injury, or they can appear days or weeks later. And an injury is a blow or a jolt to the head or the body. Not all blows or hits are going to result in a traumatic brain injury, but it can, right? And if we have repetitive blows or jolts or hits, that is a major risk factor for a traumatic brain injury, but also developing that chronic traumatic encephalopathy, which I'll talk a little bit more about here in a second. But really, a brain injury, a TBI, it's going to disrupt normal functioning, and it can range from mild symptoms that are just last for maybe a few hours to more severe symptoms that can have long-term damage to them. And so some mild symptoms can just briefly cause some mental status, maybe possibly consciousness, but it's just a brief change. And then everybody the symptoms go away, goes back to normal. More severe symptoms, what's happening to the brain, there can be a bruise on the brain, there can be bleeding, something can get torn, some brain tissue can get torn. There can be an extended period of unconsciousness or memory loss. Again, that leads to more long-term damage. This picture is a picture of a concussion, and usually that's what we're talking about when we say a TBI, because our brain sits in our skull, but it's surrounded by fluid. So it's kind of cushioned in there with all that fluid, but it doesn't mean it can't move around either within that fluid. So if we have a hit or a jolt, right, the brain will hit against the skull wherever it, you know, whichever way it's going to move. It can be front and back, it can be side to side, you know. Another thing that can happen with TBIs is there can be a penetration within the brain. That could be something like a bullet, or it could also be some broken pieces of skull that's broken off and maybe penetrated the brain as well. That's not as common as a concussion, but that's another considered a TBI. I'm going to briefly go through these symptoms because again, it's a wide range of symptoms and severity. You know, it could just be something acute. Well, they're all acute, something very mild or something more serious, right? But physically, what you might see is some nausea or vomiting, maybe dizziness, a loss of balance, maybe some ringing in your ears or blurred vision temporarily. For it to have more severe symptoms physically, any of these mild symptoms can worsen or persist for a longer period of time. But you can have a loss of consciousness for minutes to hours. There can be convulsions or seizures that you might see, a dilation of the pupils, and it can be both pupils or one or the other. You can see fluid, a clear fluid draining from the nose or the ears, a loss of coordination, not able to awaken from sleep. So we can see the difference between those physical and sensory symptoms, more mild to more severe, but also cognitive and behavioral symptoms. Again, there might be a loss of consciousness, could be a few seconds, it could be a few minutes, more severe, right? It lasts longer, a few hours, days. A really altered state of confusion, disorientation, really hard time with memory, mood changes, feeling depressed. More severe stuff is they're not able to recognize people or places, really slurred speech. It's not that they can't find this speech, it's just really slurred, profound confusion. There might be agitation with some combativeness combined with that, and possibly even slip into a coma. For those some more severe causes. So over the past 30 years, and this is from the CDC, research has linked more moderate and severe TBIs to an increased risk of developing Alzheimer's disease or other related dementias. And they occur after the original head injury. So years later, you'll start to see these symptoms. And again, repeated TBIs or blows to the head are associated with that chronic traumatic encephalopathy. From the Alzheimer's Association, studies have shown that people who experience TBI in early to midlife are 2 to 4 times more, or their risk to develop dementia in later life. So we want to make sure and put some safety precautions in place, wear our seatbelts when we're in the car, wear helmets, and not engage in as much risky behavior. Because a lot of the causes are falls. Falls and car accidents are the number one thing where we see people in the hospital or you're seeing some damage from this. It can be violence, being hit against something, or it could even be self-harm. Sports injuries is where you're going to hear a lot of it as well. And then military-related explosives or explosive blasts or combat-related injuries. The risk factors, and this is interesting, so you see more traumatic brain injuries in newborns and young children, and then the elderly population. And it all has to do with falls. So 0 to 4-year-olds, there's a lot of falls happening. And then also in people ages 60 and older, the main risk or the main cause of TBIs are falls. Young adults, that midlife stuff is mainly sports and car accidents. And then violence was a little bit higher in this age group because it might be intentional harm to the self, but you're just being struck by something or against an object. Sometimes when we're younger, we don't have better coping skills, and sometimes we get into fights, And this is interesting. So males in any age group is a risk factor for TBIs. And really, it makes sense why that's on there, because males tend to engage in more risky behavior. They are the ones that are playing the more sports. They're the one driving the cars generally, or they tend to be more drivers of motorcycles, ones in combat, right? And usually their falls are from off an object like a roof or a ladder or something like that. So with the traumatic brain injuries and then this chronic traumatic encephalopathy or CTE. CTE is a progressive and fatal brain disease that is associated with repeated traumas to the head. And it's also associated with the development of dementia later on. It's a very rare disorder. We really don't understand it very well. It's getting more attention now because of the football players and the boxers. And I know a movie came out, documentary kind of movie several years ago that brought a lot of attention to it. But with CTE, it's not related to an immediate consequence of a head trauma, especially in later life. It's really kind of the buildup of repeated TBIs or repeated head traumas over the course of years, and then you start to see the symptoms of dementia from CTE develop. So it's been found mostly in persons that play football or other contact sports, including boxing, but also in the military because of those blasts and just combat-related injuries. Some signs of CTE are thought to include difficulties with thinking, physical problems, emotional problems, and other behaviors. But again, these are thought to develop years or decades later after the head trauma occurs. And with boxers, I was reading up, it's not so much about, when it comes to CTE, about necessarily severity, because they were looking at how many knockouts somebody had. It really came down to how many hits somebody had, whether they were knocked out or not, just the continual hits for it. Knocks out didn't help the situation, but it was more about the hits. It cannot, so CTE can't be diagnosed during life, like when somebody's alive, except for the very rare individuals with high risk, so boxers, right? But researchers don't know yet the frequency of CTE in the population, and we really don't understand the causes of it either. And we don't have a cure for it. Not yet, right? So there are no specific symptoms linked to CTE. The research and the diagnosis for it, the causes and the symptoms, how we understand really any brain changes is really still in the early stages for most dementias, but really CTE, it's all in the early stages, the research and how we're understanding it. Symptoms can occur and look like other conditions, but few people that have CTE symptoms do include the basic or the same symptoms that we'll see in a more common dementia like Alzheimer's disease. So thinking issues, memory issues, impulsive behavior, can be depression or apathy, having a hard time planning or carrying out those everyday tasks. But you also might see more movement problems or balance problems, emotional instability early on. And this is more than just being agitated. It might be more severe agitation or more severe depression that you see early on. There can be substance misuse or abuse. And then suicidal thoughts or behaviors that come with CTE. And the picture here just shows me some brain imaging of what the differences that we can see between an Alzheimer's disease on the far right, CTE in the middle, and a controlled brain on the far left here. There's no official test to diagnose CTE. Like most of the dementia, it's kind of a ruling out process. So if CTE is suspected, so especially in people that have repeated head traumas, they're going to do a thorough medical history, family history, mental status testing, neurological exams, and any possible brain imaging to rule out other causes. But what we do know that's unique about CTE is it does involve the tau protein, which is the same protein that is seen in Alzheimer's disease. And that becomes toxic. So this tau protein in individuals with CTE, there is an abnormal buildup, but the buildup is in tissues around the blood vessels. And that's a different buildup than what you would see in other dementias with the tau buildup. So we do see some kind of differences, but you're not going to be able to see those differences until an autopsy for sure to get an official diagnosis. We do have, of course, advances in the medical technology, and brain imaging can help us see this better. But the official diagnosis is not until autopsy. There are no treatments to help with CTE outside of symptom management medications. So helping with any symptoms that come along, whether it's depression or agitation or pain, anything like that. And of course, more research is needed on diagnosing and treatment. So Huntington's disease, we've done traumatic brain injuries and CTEs, right? Kind of all those together. But Huntington's disease is an inherited dementia. It's very rare, but it causes a progressive breakdown of nerve cells in the brain. And I'm saying very rare, fewer than 200,000 cases per year in the United States. There is a wide range of impact on a person's functional ability, but usually what you'll see, it does result in thinking issues, but movement and psychiatric disorders. I'll explain that here a little bit more in a second. The rate of progression is a little bit longer. It's about 10 to 30 years, and people who have this disease will more than likely develop it in their 30s, 40s, or 50s. More in their 30s and 40s. 50s is a little late, but it still happens. There is a juvenile Huntington's disease that you get in your 20s, and this is even more rare, and the symptoms are a little bit different. and the disease tends to progress faster in those individuals. So what's happening with Huntington's disease is there is a mutation in the gene protein called Huntington. So what it's suggesting, or what it says, is that all of us get two genes or two copies of each gene, except for the sex chromosome. We all getting one copy of each gene from our parents, one from mom, one from dad. And when this mutation happens, the protein is abnormal. This mutation is abnormal, and it causes this protein, the Huntington protein, to create multiple copies of itself. And that's where the mutation happens, and they fold and misfold together, and they start to clump together, and that's what kills the nerves in the brain. So each child of a parent with Huntington's disease has a 50-50 chance of inheriting this gene, because you could get the mutated gene from dad or from mom. If you do not inherit the Huntington's gene, then you're not going to get it, and you can't pass it on to next generation. A person who does inherit Huntington's disease will eventually develop the disease. Again, in the 20s, more likely 30s, 40s, 50s. It's generally diagnosed based on genetic testing. Was when you get that conclusive diagnosis for it. But the hallmark symptoms that you see with Huntington's disease is really that inability to control voluntary movement. So what it kind of looks like is people are jerking, they're twisting movements, and there's also abnormal body postures that they can get stuck in. So they can have rigid muscles or muscle contractions that they can get stuck in. They don't have any control over these movements that are happening in their body. They can have poor balance, poor posture, impaired gait. They'll also start to see difficulty swallowing, difficulty with speech, and possibly a slow-eyed movement for these individuals as well. And then you have some emotional changes, behavioral and emotional changes that come with this disease. They don't have an awareness of their behavior, and they may not have an awareness of their movements either, that lack of control they have, and just those abnormal movements. They can get stuck on a thought or on a behavior or on an action. So they keep doing it over and over and over again. Lack of impulse control. Depression is pretty large in persons with Huntington's disease, and it's not because of the diagnosis, it's a symptom of the disease. Social withdrawal, insomnia is also something as well. They can have suicidal thoughts, obsessive compulsive disorder, mania, and bipolar disorder you can also see develop in persons with Huntington's disease. So with the diagnosis, if it's suspected, the doctors will do a family and medical history. They'll do neurological testing, they'll do some psychiatric evals and brain imaging, and then they'll do that genetic testing and counseling. They can also do a predictive genetic test. So for those that have it in the family, but you're not seeing any symptoms, that will be able to tell you whether you have the gene or not, but it can tell you when you'll develop it or what symptoms you'll see first, if that's part of the family. There is unfortunately no treatment that can alter the course of Huntington's. It is progressive, progressively get worse, and it is a fatal diagnosis. Medications can help with CREA, and that's the movement disorders, the movement that comes along with it. Antipsychotic drugs can also help with those movement issues, some violent outbursts and hallucinations. Of course, medications for depression and anxiety. But really, they say that you just want to plan ahead because we know, and of course, for all dementias, planning ahead, we know it's progressive. And eventually we'll need, this particular dementia needs a lot more physical care because of the involuntary movements and getting stuck in a particular posture. So knowing that and planning ahead for care down the road. So Creutzfeldt-Jakob disease or Creutzfeldt-Jakob disease, this is a human prion disease. So it's a neurodegenerative disorder, and it does have symptoms and features that are related to Alzheimer's disease and other dementias. The main hallmark thing about Creutzfeldt-Jakob disease is from the onset of the symptoms, the progression is extremely rapid and it can happen within a year. So you have onset and symptoms, and within a year, you're severe or it's passed away from this particular disease. It does have a few variants to it, and all these variants belong to a group, a broad group of human and animal diseases known as transmissible spongiform encephalopathies. So the spongiform, it kind of comes from what the brain looks like. It creates holes in the brain that looks like sponges. What happens is the cause of it appears to be this abnormal versions of this protein, this prion protein. You know, we're having a lot of these proteins in our brain, the tau protein, beta amyloid protein, the prion protein that become abnormal, right? These proteins are in our bodies and they're harmless. They're there for a reason. But with these proteins, the prion protein, the other ones, they become misshapen, they fold together, they stick together, they become harmful, they damage the brain, and normal biological processes. CJD, Creutzfeldt-Jakob disease, is very rare. It is a worldwide disease that you see, and it's about 1 out of 1 million of the worldwide population that will get this disease. Typical onset is 60 years old. This is a picture I found. So you said that spongiform thing, so the brain looks more like a sponge, kind of an image of what it looks like for this particular dementia. The variants of the Creutzfeldt-Jakob disease. There is this classic or sporadic Creutzfeldt-Jakob, and this one appears for no reason. We don't know the risk factors or why this person got it, and it accounts for most of the CJD diagnoses, about 85% of them. Tends to develop around 60, but it has affected persons in their late 20s. There's also hereditary CJD. This person there's a genetic mutation, and this person has inherited that genetic mutation associated with Creutzfeldt-Jakob disease. This is even more rare. And then you have an acquired Creutzfeldt-Jakob disease. This has come from, the disease has been transmitted by exposure to brain or nervous system tissue, usually through medical procedures and the equipment that was contaminated. So the equipment that was used already had some brain tissue or nervous system tissue on it that had Creutzfeldt-Jakob on it, and used it on somebody else, and they got it. So there are measures now to prevent that from happening. They either get rid of the surgical equipment, or they only use man-made growth hormones in certain procedures that they need to. And especially for lumbar or spinal punctures, for testing, those are single-use kits only. And you might have heard of this, or maybe you've heard the term mad cow disease, because this particular dementia did catch our attention in the 1990s when some individuals from the United Kingdom developed a variant of this Creutzfeldt-Jakob disease by eating contaminated meat from cattle, so cow meat. So they did develop, it's called a bovine spongiform encephalopathy. So that's a variant of it. I will say the classic sporadic, the hereditary, and the hereditary Creutzfeldt-Jakob disease, you really cannot get that from eating contaminated meat, and really risks of getting the acquired CJD from contamination is really almost non-existent as long as you're in countries with effective public health measures. So here in America, we're not getting it. We don't see it here. Some hallmark symptoms, again, is that rapid decline from the onset of symptoms within a year of the fatality of this disease. Personality changes, memory loss, those dementia symptoms that we typically see. Blindness also occurs more often in this particular dementia as well. So most people might become blind at some point. They can have those sudden or jerky movements with this disease as well. And eventually what you typically see is their inability to move. So they're kind of frozen, and then they'll go into a coma. And that's with that later part of the disease. Autopsy is the only way to confirm a diagnosis of this particular dementia, but they do have tests that can help rule out other possibilities, of course. So the electroencephalogram measures certain brain's electrical activity, and people with certain variants of CJD show a different pattern of this brain activity, so that can be helpful. An MRI is the same. It can show high resolutions of person's gray matter and white matter. It can help rule out other stuff for this particular dementia. And then spinal fluid tests. So they can do a spinal tap or a lumbar puncture. And so you get that fluid that surrounds the brain, and to help rule out any other neurological disorders. But also there might be an elevation of proteins that can occur in this particular type of dementia. And like most other dementias, the treatment is symptom management and pain relief for this one as well. There might be some pain with just that being frozen, stuck in a posture or something. And of course, planning ahead, knowing that we'll need help with the care for this one. And then normal pressure hydrocephalus. This is a buildup of the cerebrospinal fluid within the brain, within the ventricles of the brain, and that causes pressure on the brain. And it can damage some brain tissue or just disrupt the functioning of the brain tissue and the brain functioning. It can occur at any age. It occurs mostly in newborns and then the elderly, but most commonly it occurs in the elderly. The normal pressure hydrocephalus occurs in the elderly. It's believed to account for 5% of all cases of dementia. And we do know it can be caused by a ruptured aneurysm, of course, head trauma, an infection of some sort like meningitis, a tumor, complications of surgery, but then there's also unknown. Times we don't know what causes it. This is a picture of the normal brain, and then we can see the enlarged ventricles of what it looks like to have the normal pressure hydrocephalus. So the fluid has just filled up the brain, and those ventricles enlarged and cause pressure throughout the rest of the brain. Some hallmark symptoms you see with this is you really do see a loss of bladder control, and this can be urinary urgency or incontinence. This is an early symptom of this particular dementia, and you'll also notice poor coordination. So this is, they're falling more often, but they can complain that their feet or feel stuck, like they can't pick up their feet. So they shuffle or they take really short steps. And then just a general slowing of movement. So in turning and just trying to start to move, it's just a general slowing that's uncharacteristic, right? And then though you will see other symptoms that you would see associated with Alzheimer's disease, Parkinson's disease because of the shuffling of the feet. So this particular disorder can go misdiagnosed, or it can go unrecognized, and then persons are not getting properly treated. According to the Alzheimer's Association, less than 20% of persons with normal pressure hydrocephalus, the disease is not properly diagnosed. And with this dementia, this is one of the few cases of dementia that can be controlled or reversed with treatment. So we want to make sure that we are getting to the doctor, we're doing some early diagnosing, and they can do a variety of tests, brain scans, the neuropsychological testing, help rule everything out, right? But then that lumbar puncture or spinal tap to relieve the pressure off the brain, to drain some of that spinal fluid is what the treatment will do, and the symptoms can alleviate. If this normal pressure hydrocephalus is not treated early on, the symptoms will get worse. And this condition, is fatal if it's not treated. So what happens as far as the treatment goes is they will place a shunt into the brain and drains that cerebral spinal fluid into the abdomen, where then it can be absorbed as a normal part of the circulatory process. So normally our cerebral spinal fluid is absorbed and it goes through a whole process and drained, and we do this whole thing, but that shunt's put in to help with that process for persons that have normal pressure hydrocephalus. When that happens, those ventricles that were enlarged can now go back to their normal size, and then those symptoms can alleviate. I will say that procedure does come with high risks. So we really want to make sure that you have regular and frequent follow-ups with the physician, because they're really able to understand or see subtle signs that might down the road can indicate that there is a problem with that shunt. But I will say success of treatment does vary from person to person. Not everybody will see a full recovery, but they might see some recovery. So some trials suggest the improvement of symptoms can range between 50 to 90% of all persons that have the treatment and have done early on. But it's also been shown that some people, the treatment may not last long term. So the symptoms might come back. And here are the resources we've used for this. And then our information as well. And now I will kind of a lot of information, just a few minutes over. And I know there was a chat over here. Your slide. So talking about going back to traumatic brain injuries and the severity of it and TBIs being a cause of dementia. What we know, or what they know so far, is that while you may have had one traumatic brain injury, your risk is increased a little bit to maybe develop dementia later on in your life. It can also contribute to an earlier onset of another dementia, if that kind of makes sense. So if I know, or if I'm going to get Alzheimer's disease and I had a TBI younger, it's been associated with that, has kind of quick started, or I had the Alzheimer's disease develop a little bit sooner than it maybe wouldn't have if I didn't have a traumatic brain injury. If that answers your question or not. So again, we still don't know a whole lot about it. A lot of research being done on these things. And the brain is so complex. I think I've said this before, the more we learn about the brain, kind of the less we know, because it is so complex. We're learning new things every single day, but sometimes the new things bring up new questions, right? And new theories and new treatments and everything. So there's a lot of information on these dementias. Does anybody have any questions or comments or experiences they want to share?
Hey, Jamie, on the Huntington's, you said that a person could get stuck in repetitive talking. Is that just for a short time, or you know what I'm saying, a phase that they go through, or is that all the time with them?
It would depend on the person, but I would really have to look into it, but I'm pretty sure it's a phase. So it's a symptom that will come and then they can get stuck on the thought or that movement.
Yeah.
And it's a phase, and that phase may be 2 days, it may be 2 years, yeah. Right? But then as the disease progresses, that will go away and something else will come up.
Okay.
Right? Mm-hmm.
Thank you.
Yeah, thank you. Well, I appreciate everybody's being here. Again, I'll send out the slides and the recording and our upcoming programs. And we hope y'all stay warm, and we will see y'all soon. Thank y'all.